Funding for this program is made possible by the Corporation for Public Broadcasting, Louis B. and Louise Hirschfeld Coleman, Sue and Edgar Wackenheim III, and contributions to participating stations. Coming up, a new cancer treatment changes lives.
It's 10 times better than the surgeries just because I'm able to live my life.
And a robot in the operating room.
They have motion that is far greater than the human hand or fingers, so it allows us that dexterity to get into narrow spaces.
Exploring the frontiers of science. Probing cutting-edge technologies. Seeking answers to the big questions. Welcome to SciTech Central. Battling cancer is never easy, and the side effects of radiation therapy can be debilitating. But what if doctors could focus radiation precisely on the tumor and leave surrounding tissue unaffected? A new center in Orlando aims to do just that. Central Florida has a new tool to combat cancer. In April 2016, the UF Health Cancer Center at Orlando Health opened a facility that offers proton therapy.
Proton therapy uses charged particles, protons, instead of X-rays, which is what we've used for conventional radiation. Proton therapy releases radiation more precisely in a way that X-rays can't. X-rays will go into the body and then release radiation in the tumor, but also release radiation past the tumor. Protons, on the other hand, go into the body, but when they reach the tumor, they release all of their dose, and then there's no dose beyond the tumor. So this allows us to treat cancers, especially in very sensitive locations, with less risk to the patient. In a way, it's like a controlled explosion right inside of the tumor.
The Proton Therapy Center at Orlando Health is the first of its kind in Central Florida, and one of only 23 in the country.
Proton therapy is a better type of treatment for a variety of cancers. Some of them are going to be cancers that are located in very critical areas like the brain, the eye, the spinal cord, or other very sensitive parts of the body. Basically, proton therapy delivers less radiation to the body to treat the tumor the same amount. And often that magnitude is 50%, sometimes it's 60–70% less total radiation to the body to achieve the same effect inside the tumor.
Angie Oswald is battling a rare and aggressive brain tumor called a hemangioparasitoma. After 9 years and 2 surgeries, the cancer has returned again. This time, proton therapy will keep her off the operating table and should limit long-term side effects.
They're able to treat a fairly large area, and actually 2 areas at one time, which is pretty amazing. And so the idea is that this cancer won't grow back in these areas, and ideally I could be cancer-free indefinitely.
Angela has an extremely rare tumor, and she's being treated with an exceptionally complex treatment plan that targets some of the lining of the brain, but also some of the major veins that are inside the brain. And what we end up creating is an extremely complex shape that reflects the anatomy of the brain and the distribution of the tumor.
It's 10 times better than the surgeries just because I'm able to live my life, I'm able to work, I'm able to be home every day. With the surgeries, it was definitely life-changing. I had to leave work, I had to take time off, I had to have family come take care of me. I was thrilled when I found out I did not have to have another surgery. I think that's really the best part, is just being able to continue with everyday life and with minimal impact to my family and my daily life.
If we had used conventional radiation, the amount of brain that would have been treated would have been extremely large. And that would have had effects for the rest of her life. It would have increased the risk of stroke, increased the risk of vision loss, it would have increased the risk also of neurocognitive change. So using protons, we're able to limit the dose extremely well to just the areas we need to treat. As a person that treats pediatric cancer and brain tumors, I want to give my patients the best. And I finally can tell them that we are giving them something that's as good or better than any treatment available in the world. Proton treatment lets us treat these patients in a way that's effective for tumors and has the lowest risk of causing them side effects, not just in the next few weeks or months, but for the rest of their lives.
Nanotechnology, 1 nanometer is about 1 billionth of a meter. So if you make it into a nanostructured or nanoparticle, then the properties, the physical as well as chemical properties are going to change. And that's the whole point of nanotechnology. Once you get that properties changed or enhanced, the applications are limitless.
Nanostructures have a lot of applications in hydrophobicity and making it so that water and oils don't stick to a surface. We want to do self-cleaning medical equipment because it's such a big issue. Something like 100,000 people a year die from infections they acquire in a hospital, and that's just from materials in the hospital not being clean. So the biggest challenge is actually the challenge we're solving, and that's the cost to manufacture. Nanofabrication is historically expensive.
What we have generated is a different type of printing.
Right now we're trying to make everything self-cleaning, or as many things self-cleaning as we can. We're changing the topography or the existing layer that's already there, and it's got a permanent nanostructure pattern on it that gives you the benefits.
So these are some of the different types of nanostructures that we can imprint and have imprinted using our technique. We can do different kinds of geometries, nano grooves, different kinds of shapes. These types of structures are very good for different kinds of optical applications or for self-cleaning. In fact, when you put water on these are super hydrophobic, so water will actually bead up and roll off of it.
We're about 200 times cheaper than current methods, and we're significantly faster. So we just hope to make nanotexturing available to the masses so that everyone can have access to nanotechnology for absolutely everything we do.
Robots building cars is one thing. Robots doing surgery is quite another. 15 years after its introduction, a robotic system for common surgical procedures may have finally come of age.
Tiny robotic hands controlled by a surgeon are mimicking precise sutures on human tissue.
You can take this needle and really move it any which way.
This is Da Vinci, the multitasking, multi-armed, multi-million-dollar surgical robot.
They have motion that is far greater than the human hand or fingers, so it allows us that dexterity to get into narrow spaces and do maneuvers minimally invasively that were not possible before.
Robotic surgery has had its kinks over the years. Since Da Vinci premiered 15 years ago, there have been several fallouts over its success compared to traditional, non-invasive or laparoscopic procedures. But doctors are finding the system is improving patients' lives, and they're encouraging fellow practitioners to get trained.
Instead of making a 12 to 16-inch incision that is traditionally made for open surgery, we're using multiple quarter-inch or smaller incisions. So clearly there is much less pain after surgery. There is much quicker recovery for patients with a shorter hospitalization and return to their baseline lives much quicker.
This entire system translates to a surgeon's hand. One tiny maneuver with this arm, and it could be a 360-degree rotation. That's something I couldn't quite get the hang of when I tried my hand at it.
Close your middle finger and your thumb on both hands.
Oh, wow.
And you're in control.
It was traditionally used for hysterectomies, hernia repairs, prostate and cancer removal, but now
we're using the state-of-the-art technology for GI or gastrointestinal diseases and cancers. We're using it for colon and rectal cancers. We're using it for cardiothoracic procedures, including both valves and lung cancers.
Dr. Tanuja Damani at St. Joseph's Medical Center in Patterson controls the robot through the computer screen. It's a lot like being part of a 3D video game.
It gives us a 10 times magnification compared to naked eye and gives us a three-dimensional view, which is high definition.
She says they've seen more patients putting off surgeries because they're unable or worried about taking time off from work. That often results in greater complications, but this surgery negates that.
I waited about a year and a half. And then it just got ridiculous.
Patient Lidiana Cayavega says she was convinced to have the surgery after being told she'd be back at work within a week.
I was in the operating room at 7 a.m. I was out of the operating room at 11:30. I was walking out of the hospital at 3 o'clock. And at 7 p.m. that night, I was outside playing with my dogs.
Surgeons say, as with any procedure, the prognosis depends on the patient and condition. They're hoping the more it's used, the more comfortable people will be with the high-tech helper.
Computers that seem to express emotions are no longer science fiction. And now, a Seattle researcher is creating computer software that can recognize and rate emotions in humans, which could lead to better training for psychotherapists.
We've come a long way with artificial intelligence mimicking human emotions. But what if software programs could detect emotions? Dr. David Atkins at the University of Washington is working on a system that can do just that. The goal? To train and rate therapists.
We're in the AI bucket, yeah.
Over 10% of Americans use psychotherapy or talk-based therapy to treat mental health issues. But what makes a good therapist? Atkins and his team have developed software technology that records the audio from a therapy session, then analyzes that audio, looking for specific quality metrics such as empathy.
Some of that is literally what are the words that are being said, but also the way in which words are spoken. The tone and the inflection in someone's voice can be important in terms of understanding the interpersonal dynamic between a counselor and their patient.
Atkins says this dynamic can help measure how empathic a therapist is, which in turn rates the quality of care delivered to clients.
So from your perspective, the drinking isn't really getting in the way of the application process, but from your parents' perspective, they're still a little concerned.
Right. Exactly.
Today, Atkins is recording a mock therapy session with Grin Lord, a licensed clinical psychologist.
Hi.
Hello.
Less than an hour later, Atkins has the results from Lord's session.
As you can see here, these are two overall scores for the entire session. So this is characterizing overall how well did the session go. So we can see here that you were really empathic. You're summarizing what the client said. So we can see down here that Kristen is not just a party girl, and that's what you said at this time.
Oh, okay. That was a complex reflection. Mm-hmm. That's so cool that you can zoom in on what I said. How fascinating to be able to get a measurement that says, like, yeah, you and this client were in tune, like objectively. Your voices were syncing, your tone was syncing, you know, you were tracking each other in what you were saying and how you were saying it.
Atkins is collecting feedback from mock sessions like Lord's before he heads into real clinical settings. And he admits it's not all positive.
Some of the initial feedback that therapists are giving us are highlighting, some places where honestly we're making a mistake. The system is not perfect. And so the therapist said, hey, look here, your system said I'm giving information where I was really asking a question.
Once the program is debugged and the trial phases are complete, Atkins believes this technology can be used to train therapists and help even rate their quality of care. But are we ready to have a software program determine the quality of care therapists provide?
It's not for the computer to judge therapists, but that was my initial fear when I heard about it, and I really don't see that happening. If anything, it's going to eliminate long coding times and be able to have outreach to rural communities and places that couldn't have expert evaluators there.
This is clearly one piece of the puzzle. We also want to know how well is the patient doing? Are they improving? And so any feedback that we would generate from our own system needs to be part of a package that would really help define quality care in general for counseling and psychotherapy.
What is precision medicine? It's based on the idea that diseases work differently in different people depending on their genetics, environment, and lifestyle. For example, if we know that some genes affect how diseases respond to treatment, then doctors can use that information to help pick the right treatment for a patient based on their genetic code. And doctors are already using this kind of approach. Cancer cells, for instance, usually have genetic mutations that allow them to grow and spread, and specific mutations can affect how the cancer will respond to certain treatments. So doctors can test for those mutations.
A diagnosis of Alzheimer's, an incurable brain disease, is a frightening prospect for anyone. For those struck by early-onset Alzheimer's, it can be especially devastating. But an experimental drug trial in St. Louis could lead to treatment and prevention of this intractable malady.
Once a year, Jeff Burrell flies to the Washington University Med School in St. Louis from his home in North Carolina. for a series of tests and scans. Researchers want to see what's happening in his brain.
My mother and all of her brothers and my grandma passed away with early onset Alzheimer's.
And by early onset, he means his age, 46. If he misplaces his keys, it's hard to laugh it off as a senior moment.
But little things like that happen to you, and it's, it makes you stop and think, oh gosh, am I showing signs? It's scary. It's scary.
Early onset Alzheimer's is caused by an inherited genetic mutation. It's in his family, so Jeff knows he has a 50-50 chance that he's next. But it's that predictability that makes people like Jeff and his sister and 2 cousins ideal subjects to try out experimental treatments.
Now, this population is incredibly rare, so this is a worldwide trial run across many different countries and languages to get enough people together to demonstrate whether these drugs will have a benefit. And so it's not an easy trial.
Washington University Med School neurologist Dr. Randall Bateman is directing what's called the DIAN-2 study.
We believe that this is the era in which we will begin to change the course of Alzheimer's disease with highly effective treatments.
The study is being conducted in centers around the world so that Jeff and other subjects can get their experimental drugs or placebos close to home. They're also regularly tested for symptoms like memory loss. And researchers know what causes that. Amyloid beta plaque builds up for many years until the clumps finally begin to interfere with brain functions.
In Alzheimer's disease, it's really a 30-year process. And so what you're really talking about is the last 7 years is what clinically we see as doctors, but the process started 20, 25 years before that.
But it used to be they could only know what had happened by examining the patient's brain after death. But now advanced scanning and imaging technology shows it happening in the living, building up before the symptoms emerge.
Okay, Jeff, you're doing great. This next one is about 6 minutes.
Test subjects make annual visits to the few medical centers that have those machines for a series of scans that will be compared to last year's.
The scan of Jeff's brain is going to take about an hour. Now, he's not going to know what they find or what they don't find, and frankly, he doesn't want to know.
I don't ask a whole lot of questions, actually. I used to really try to get involved in it, and now the more it goes, they're talking over my head. I turn wrenches, and not my cup of tea.
You can see the changes of amyloid deposition throughout the brain.
These are not images from Jeff's scans, but if he has Alzheimer's and the steady buildup of plaque, this is what it would look like from one yearly scan to the next.
This kind of imaging, this is what you would only find in an autopsy.
Exactly.
And say, oh, look, it was Alzheimer's. Right. Now you see it happening.
In real time, in real life.
Wow.
We can see the changes of Alzheimer's occurring in these patients. Now, the drugs that we're administering are designed to target this amyloid beta protein.
And if one of those drugs is, in fact, stopping, preventing, or reversing the damage, they will see it in these scans.
Okay, Jeff, we are all finished. How are you feeling?
He doesn't know, and no one's allowed to tell him, if he actually has the genetic mutation, or if he's got Alzheimer's, or if he's getting a test drug or a placebo.
I don't know a thing. I don't know a thing. I don't know if it's helping. I don't know what kind of medicine dosages I'm getting. I don't know. And do you want to know? Do you want to know? Do you want to know your dad?
There are multiple trials running in parallel right now. Our trial will have its first readout towards the end of 2016, 2017. And so that's when we'll have the first information about whether these drugs are hitting their targets, the biomarker measures of Alzheimer's disease in these family members, and which of these drugs may be then more likely to have a benefit in this population. Several years after that, we may have the first clinical readings of what the cognitive benefit is of a drug in preventing Alzheimer's disease. But the number one reason why people do this study, interestingly enough, is not for themselves. It's not to protect themselves against Alzheimer's disease. The number one reason these families do it is because they do it for their other family members.
Like I said, if it doesn't help me, maybe it'll help our children and other people's children down the road.
For most people, brain surgery is a synonym for the most difficult, complex task anyone can imagine. But at a New Jersey hospital, doctors are treating Parkinson's disease with a surgical procedure that's so simple, it doesn't even require anesthesia.
The tremors in 45-year-old John Leonard's hands and legs are so severe he's unable to work or drive. Side effects from the strong medications doctors in his native Arizona initially prescribed left his personal and financial life in ruins.
For the last month, he's spent most of his time in his room because his legs shake so much, the tremors were so bad that he couldn't get comfortable.
He's what we call tremor dominant, early onset Parkinson's disease because he was diagnosed in his mid-30s.
It's one of the worst cases doctors at JFK Medical Center in Edison have ever seen. But today he's undergoing deep brain stimulation surgery, a procedure used to turn those tremors off.
So this is the lead that would connect to the microelectrode.
Dr. Asif Bashir and his team are inserting a thin, insulated wire called a lead. It's connected to another wire that monitors the activity of nerve cells and targets the signals that cause tremor and Parkinson's disease symptoms. The kicker? John is awake but mildly sedated for the entire procedure.
What do you think? Okay.
So we are basically listening to the brain. As we pass from the thalamus into the deeper part of the brain, which is the subthalamus, the activity goes up, and Dr. Hanna and our team is able to track the waves over there as well as we can listen to the activity.
They use an MRI and audio cues to locate the exact target in the brain where the nerve signals generate the symptoms. Listen closely. That rain on a tin roof sound is actually John's brain responding to the electrode.
We can hear the brain activity go up, telling us we're getting close to the target.
They'll send electrical impulses from a neurostimulator through the wire into the brain and block the signals causing the tremors.
It's very similar to a cardiac pacemaker, and it goes in the same area of the chest as a cardiac pacemaker. It's just about the same size.
Right now, doctors are fine-tuning and trying to find the appropriate balance between the highest voltage needed to turn the tremor off without causing a side effect.
That target is not resolving the tremor of the arm and the leg. So we're going to implant a second electrode in the same side of the brain at a different site that will get the tremor under control, and he will be able to reduce his medication significantly, if not completely.
Second time around, and they've got it.
How about if we turn it on again and take over the tremor? There we go. The prognosis is very good once you have the tremor under control. Then basically, as long as you keep on changing the generator every 4 or 5 years, all the motor symptoms are controlled for life.
It means it's not the end of the road for the young father of two. It's the start of a brand new one.
That's all for this week on SciTech Central. Thanks for watching. Join us next week for more stories from the frontiers of science and technology. Funding for this program is made possible by the Corporation for Public Broadcasting, Louis B. and Louise Hirschfeld Coleman, Sue and Edgar Wackenheim III, and contributions to participating stations.